So good afternoon, everybody. Now we have a session in the afternoon. Maybe all of us tired now by the whole day's work. I have the faculty with me, Dr. Suviraj Jain. She would speak on basic principles on scleral fixation, achieving back stability. A stalwart, Dr. Dinesh Garg from Ludhiana, from Advanced Eye Care Center. He would speak upon aniridia eye, scleral fixation in pediatric and refixation of dislocated IOL. Dr. Rajesh Sinha from AIMS would take. And I would request as Dr. Rajesh is busy with the inauguration session, I would request him to go first. And that would be followed by Dr. Srishta Mitra. She's a very enterprising and promising VR surgeon from Dr. Shakeen Singh Eye Dental Hospital. And the last would be the Dr. Shakeen Singh from Dr. Shakeen Singh Eye Dental Hospital. So not wasting much of the time, I would request Dr. Sinha to please go ahead with this presentation.
Thank you, sir. Thank you for this opportunity of including me in this wonderful webinar, which is the topic which is so close to my heart, scleral fixation of IOL. And in pediatric eyes, we have done quite a good number. So I would like to share my experience with you all. There are various indications for scleral fixation of IOL and in children. That includes ectopia lentis, which can be idiopathic or which can be associated with systemic associations. Now, in pediatric eyes, there can be conditions wherein we have progressive zonulopathy. Now, if it's a progressive zonulopathy, we have an option. Like in any zonulopathy, we have an option of fixing the bag or removing the lens in the bag completely and do a scleral fixation. Now, if the zonulopathy is not progressive, we may think of fixing the bag, but there are many children wherein there have been progressive zonulopathy, the bag has been fixed, and later on, 10 years, 15 years later, the whole complex bag and everything gets fibrosed and shifts on one side. So any condition wherein there is progressive zonulopathy, my preference would be a scleral fixation of IOL. If the patient has been operated for lensectomy, if there was previous trauma causing damage to the capsule and the zonules, if it was a complicated lens surgery, in all these conditions, a scleral fixation of IOL can be done, is an option, because it is preferable not to use AC-IOL in children, because initially you may get good results, but what we have seen over a period of 15 or 20 years, the eye in which AC-IOL was implanted in the child, we have a couple of such cases.
The
cornea decompensated. Now, the question is at what age it should be implanted. There is controversy in that. People say 10 years, 5 years, 2 years, 8 years. My preference is any age equal to more than 4 years. The reason is this, that by the end of 3 years, the growth of the eye is complete, and you may give 1 year margin to just look for any other change. And then after that, you can go ahead and do a scleral fixation of IOL. Now, I would just like to show a small video clip wherein this is a case with an extreme subluxation, wherein one may think of fixing the bag by segments and by rings, etc. But if it's a progressive zonulopathy, in that case, I will not prefer to do a bag fixation, and I will do a scleral fixation of IOL. This is a technique which I have modified my own way. The sclera is marked at 1.5 and 3 millimeter positions. And then I make 2 radial incision on between the 1.5 and 3 millimeter positions, do a lamellar dissection, create a flap, and also a groove adjacent to the flap. So this is how we create the flap, and then the lamellar dissection it goes beyond the second incision, and then you create a groove, and which is adjacent to the flap. So the advantage is that the base of this groove is at the same plane as the groove. And then in such cases, we have described the intralenticular aspiration of IOL. This was published way back in 2003 in JCRS. When we describe this technique, we create 2 openings in the lens, and then with the help of a bimanual irrigation aspiration, the irrigation cannula not only stabilizes the lens and keeps it in the center, it also hydrates the cortical fibers, and then with the aspiration cannula, you keep aspirating. So you ensure a complete aspiration of cortical fibers and no cortical fiber falls behind. And once you are through with that, then you do you use a vitrector to remove the capsule, do a little bit of anterior vitrectomy, and then after that, the main incision is made, and then a multi-piece IOL is implanted. See, this is a 3-piece IOL. The lens fixing forceps is introduced through the stab incision made at the scleral bed on one side. One haptic is exteriorized, and then the other haptic is also exteriorized. And then once it is done, you tuck the haptic into the groove, and then put fibrin glue. You place the flap, and then you put the conjunctival flap also and stick to it. So I'll just move fast in order to save time. And there are various techniques of doing fixation of IOL. There can be intrascleral haptic fixation, which I showed. There can be transscleral suture fixation, which was started way back in, by Malbrand long back. So we just wanted to compare the stability of IOL, and we did an intrascleral haptic fixation of IOL, and UBM was done, and we found out that the lens was quite stable. You can see with the movement of eyeball, the lens is not moving at all. It is quite stable. And in a case wherein suture fixation was done, you can see with the movement of eyeball, the lens moves quite a lot. Many times it touches the iris. It can cause pigment release, etc. with the movement. So this is the advantage that intrascleral haptic fixation provides more stable fixation of IOL. And also there are certain problems of sutures fixation, like knot erosion and broken fixation sutures. Sometimes sutures get dissolved, etc. We did a long-term study on pediatric SFIOL. It was a large series, 118 eyes of 82 children. The mean age was 10 years. A mean follow-up was 31 months. And we found out that the visual acuity improved significantly. There was hardly any complication in these cases. Just 3 eyes having a little bit of vitreous hemorrhage, 3 eyes had slight tilt, etc. So this article has been accepted in the Eye and Contact Lens Journal for publication. And we found out that the long-term outcome is quite good. Another point I would just like to add, what I have to present is, if the IOL is decentered, what will you do? So decentration can be seen because of small length of haptic tuct, or post-traumatic slippage, or intraocular procedure causing direct trauma to the haptic. This is a case wherein the haptic has has slipped on one side. So conjunctival peritomy is done, and you have to create a separate flap. If you try to open up the previous flap, if it's very early, then you can still lift up the flap. But if it's a little too late, there is so much of fibrosis that it's better to cut with the crescent blade and create a flap, hold the haptic, exteriorize, and then you can fix it. So if one haptic has slipped, or because of trauma, because of less haptic, introduction into the groove, etc., then in that case, there is chance of haptic slippage and the IOL can get decentered. So this is a way wherein we can refix the IOL. So thank you very much for your patient listening. And I try to hurry up because we all know that we have to finish it by 5:25. So thank you very much. I thank Dr. Shakeen Singh for inviting me in this instruction course, and I thank all the audience for the patient listening.
Thank you, Dr. Rajesh, for a wonderful presentation. Any question, Dr. Dinesh, we want to discuss with Dr. Sinha?
No, I think that's fine. So you are using anterior chamber maintainer, no? Most of the times, like
I use AC maintainer, 23 gauge AC maintainer for doing all the procedures.
Yeah, in fact, like I just tend to put a pars plana cannula for these. So
yes, it depends on the person. If somebody like a vitreous surgeon like you will prefer doing a pars plana. Now, in certain scenarios, I prefer pars plana because I also have some training in vitreous surgery. So I do place pars plana cannula in some scenarios wherein if the chamber is very shallow, if the iris is badly damaged, if there is a lot of synechia, or if it's a hypotenuse globe. So all these factors, or it's a optimized eye. So all these conditions, I prefer to put a pars plana irrigation cannula.
Nowadays, actually, 23 gauge 6 millimeter are also available. So
Yes.
These situations, we can always use those.
So
yeah, we can use that. We can leave it sutureless as well. But what happens that if you've done a little bit of vitrectomy, sometimes it becomes difficult to leave sutureless in all these cases, unless it is a 25 gauge or a 27 gauge.
Yeah, definitely.
Is a bit dicey. Sometimes you do have to put a suture in that also. I hope you agree with that.
Yeah, I agree with you.
So Dr. Sinha,
sometimes we do have to put a.
So your proposal is AC material is as good as pars plana cannula?
Yes, absolutely, sir.
Yeah.
Thank you. Can I
think
request
the trocar cannula system has also been developed for AC.
Yeah.
That's very
true. That's very true.
Yeah. Good. Thanks.
Can you go ahead with the second presentation? Can I request Dr. Sivera, please? Are you ready, ma'am? Ma'am, you are muted. Please unmute yourself.
Dr. Rajesh wants to sign off, I believe. He wants to go.
Yes, sir. I will seek your permission to.
Thank you, sir. Thank you so much for the time you have given to us.
Thank you, Doctor. Please. Thanks.
Thank you.
I'd like to present my paper now. I'm unable to do this on the computer somehow. I'm going to try and share my screen and share my video on the phone itself. Thank you very much. Gosh, it's...
Dr. Dinesh?
I think you'll have to continue without me. I'm trying to get it connected.
Okay.
It's not happening. I'm extremely sorry. I am trying.
So can I request Dr. Dinesh if you can start?
Yeah, I'll start sharing my screen and then I'll carry on with my presentation. Can you see my screen, sir?
No. Start sharing.
Is it there? Is it there now?
Right.
Can you see my screen?
Yeah.
So is my presentation visible?
Yeah, it's there. You go ahead, please.
So thank you, Dr. Shakeen Singh, for giving me this opportunity, and other panelists. Good evening, everybody, and good evening, attendees, for coming in at a little late hour. So my presentation is on scleral fixation in an aniridia.
I requested the other person to start after him.
My presentation is on scleral fixation in an aniridia eye, and I'll be presenting a couple of videos of aniridia IOLs being scleral fixated in these post-traumatic eyes. So I have no financial disclosures to make. I'm working in Ludhiana at Advanced Center for Eyes. As you all know, penetrating ocular trauma frequently causes combined lens and iris tissue damage, resulting in traumatic cataract, corneal irregularities, traumatic aniridia, which may be complete or partial with loss of lens iris diaphragm function. And the management of these patients with coexisting traumatic iris deficiency and cataract is often very challenging. due to the complexity and various associated other ocular pathologies. Chief complaints in these patients are usually photophobia, cosmetic defect, impaired vision, and depth of focus loss. And the options which we can technically use in these patients is either to use iris diaphragm lenses or segmental prosthetic iris devices, flexible iris prosthesis, tinted or painted contact lenses over a intraocular lens later on, or we can always use an aniridia intraocular lens, which is a very good option in these situations. So I'll be presenting two of these cases which are managed with the aniridia intraocular lens implantation. First video is, this is one of my cases. He came with a trauma and I did the primary repair. This patient was done almost more than 10 years back and he had a very long follow-up of almost 6 years. And he, in fact, achieved a visual acuity of 6/6 with glasses, although he had secondary glaucoma later on after a few years, which was managed medically. So this is the first case. You can see the corneal sutures. When I did this surgery, I was using 20 gauge vitrectomy system. So we have placed a 6 millimeter infusion cannula at 3 millimeter away from the limbus or in the pars plana. This is to maintain a steady intraocular pressure throughout the surgery. A large conjunctival flap is made and hemostasis is achieved. A scleral or a sclerocorneal tunnel is fashioned, groove is fashioned of about 10 millimeters to accommodate this large lens, and triangular scleral flaps are made to stitch these sutures. Anterior chamber is opened. Partial vitrectomy was already done in this situation. And there was a total aniridia, so there was no need for any further anterior vitrectomy to be done. In this case, I used 10-0 polypropylene suture. Nowadays, I am using 9-0 polypropylene. And this is the lens from a company called Hoffman in Holland. So these are basically custom-made aniridia lenses, and it has worked very well in our hands. Actually, in even last 10 years, it has not even given off any color or anything. This is it gives very good cosmetic appearance as well as the intraocular correction. So the scleral sutures are being tied under the flaps. You can see a lot of aggression of fluid, but the intraocular pressure is maintained because there is a continuous flow of fluid from the pars plana cannula. So then the large wound again needs to be sutured with a 10-0 polypropylene. And these are the sutures of previous surgery, because he had a trauma with a large wound, and the whole of the lens and the iris diaphragm was pushed out. So we have used sutures in this surgery, and this is the post-operative photograph after 10 days of surgery, and this is 5 weeks after surgery, where he had a visual acuity of 6/6 with -2.5 cylinder at 95 degrees. So this is a follow-up photograph, almost 5 years and 9 months down the line, when he still maintained a visual acuity of 6/6. Another video is with the surgery done more than 5 years back, although he did not come for follow-up after a few months. He also achieved a visual acuity of 6/12 with glasses, and intraocular pressure at that time was normal. So this surgery was done elsewhere. He had a corneal scar. We fashioned the scleral flaps and a corneal groove 10 millimeter was made. And in this surgery, we have used a 23 gauge trocar cannula system. And we have done anterior vitrectomy as well. Then the anterior chamber was entered, the incision was enlarged. The 9-0 suture was used in this situation. 9-0 polypropylene was used. The suture ends were brought out, and in this case, the person asked for a black colored aniridia lens, which was specially ordered and custom made for the patient. It takes about a couple of months to deliver, but at the end, it gives a good cosmetic result as well as the intraocular result. So same way, the lens, this is a PMMA kind of lens, because aniridia lenses are large lenses. You need a large incision and fixation. So similarly, the polypropylene suture is buried under the scleral flaps. On both sides. And the corneal wound is stitched with 10-0 polyamide. Again, we have not used glue or sutureless fixation here. And the intraocular pressure is maintained throughout the surgery because of the pars plana cannula. Pars plana cannula is inserted at the beginning of the surgery and removed at the end. And the conjunctiva is stitched. So this is the first post-op day photograph, and 2 weeks visual acuity was 5/60, which later improved to 6/12 with correction. So in aniridia IOL fixation, pars plana cannula is a very important part. It is placed in the beginning of the surgery and maintains a steady IOP. At least 10 millimeter sclerocorneal incision is given. And the triangular partial thickness scleral flaps are made for suturing of these stitches. And pars plana cannula, of course, is maintained throughout and removed as a last step of surgery. So to conclude, restoration of normal vision and good cosmesis after surgery as severe as leading to complete aniridia and traumatic cataract, although not unique, is very surprising. And aniridia IOL is a very beneficial therapeutic option for achieving mechanical, physiological, optical, as well as cosmetic success in these eyes with coexisting aniridia and cataract. Thanks for your patient hearing.
A wonderful presentation. So as you have already mentioned, the large size of the IOL would require a bigger incision size. So is the secondary glaucoma, and I believe the astigmatism too. So we need to be very careful about the astigmatism.
Yes.
And do you recommend the tunnel or the limbal incision for these patients?
How do you get to the information?
We go as far as possible towards the sclera, but because it is a very large incision, tunnel of course can be made, but that tunnel also will have to be at least 8 to 10 millimeters. If 8 millimeter tunnel will probably fit in 9 or 10 millimeter IUL. So sometimes you don't want to take a chance because these are custom made lenses and you don't have any backups. So I would recommend this, and this works well in my hands. But of course, that's probably a personal preference.
Though endothelial is a big challenge in all these patients, but I believe with the scleral fixation, aniridia lens would be more contributed to this jet damage. We need to follow these patients more closely for the endothelial cell count also.
Definitely. This aniridia in itself can cause secondary glaucoma.
Yeah.
And of course endothelial loss. But as I said, a steady maintenance of intraocular pressure decreases the intraoperative, at least, loss of endothelial cells. It will not completely remove that chance, but at least that softening or folding of corneal tissue is not there when you have a continuous flow of intraocular fluid.
Dr. Dinesh, there's another issue which I wish to discuss with you. Like these are mostly the post-traumatic patients. So
yes, sir.
Is there any patient you have seen which has gone in hypotony, low pressure, post-implant? Or I would be more precise, ciliary shutdown.
Not these patients. If you have done a good anterior vitrectomy, then that membrane formation all over the ciliary body will not be there.
Okay.
But if you have not done a good vitrectomy and there is fibrosis around that ciliary body, because sometimes what happens is that we see hypotony and we feel that this eye is not going to behave well and we don't take it up for surgery. But we have seen when you take up these surgeries, take up these eyes and do a good membrane removal, anterior membrane removal along with synoculosis as well as a good anterior vitrectomy. The functional results as well as cosmetic results are sometimes very gratifying. Although trauma eyes, as you have said, they are for long-term follow-up and anything can happen even over a longer follow-up. These eyes are even prone to detachments later on and other things because even they have had at least 1 or 2 surgeries before we take them up for this kind of a situation. So these are not plain and simple fresh eyes where you have done this surgery.
So to sum up, we need to be very careful for customized planning of the surgery, incision site, glaucoma, frequent follow-up, more closer follow-up, and endothelial cell count more frequently.
Yes. Even for congenital cataracts and even for, in fact, a trauma eye, even a blunt trauma, the chances of glaucoma are going to be there for umpteen number of years. Maybe they need a follow-up throughout their life. Angle recession angle recession might present few years down the line.
Exactly.
Yeah.
Thank you, Dr. Dinesh, for a wonderful presentation. And Dr.
Thank you, sir.
Please unmute yourself, please. Dr. Svera, please unmute. Can you go ahead, please?
All right.
Dr. Svera, she's going to speak.
I should present my...
Yeah. Dr. Swira is a very prolific surgeon from Bombay. Often we go across her teaching videos towards phacoemulsification. It's really wonderful watching that, ma'am. I must share with you. So what she's going to share is the basic principles on scleral fixation, achieving bag stability, the capsule tension ring segments. Thank you, Dr. Swira. Please.
Thank you. No?
Yeah, go ahead, please.
Yeah.
Dr. Swira,
Yes, sir.
could you do it? Are you ready?
So I'm presenting it. Are you able? You're not able to see it?
I am unable to see. Have you shared the screen? Yeah. Share your screen. We are unable to see your screen. Dr. Dinesh?
I think, sir, you'll have to.
Dr. Sarajita?
Yes, sir.
Yes, yes, sir.
Yeah, it's there, ma'am.
Now we can see your
Yeah,
screen.
now we can see. Yeah. Yeah.
Ma'am, the audio is not there.
Go to the slideshow, please. And audio is not there. Dr. Swira, your audio is not audible.
Sir, can you hear it?
We can hear you, but not the video.
Okay, I'll tell you what. We give it one last chance. I'm starting to speak now. See if it works. All right, I'm going to speak along with it.
Yeah, that would be better.
Where are we? Share.
Go down to screen.
Yes.
Let's start now. Go here.
Yeah.
I'm going to speak now. Right.
Okay, that's better. Yeah.
Managing a grossly subluxated cataract can be a challenge in the most experienced of hands. Understanding the principles, options, and the techniques of fixation of the capsular bag is imperative in achieving an optimal end result. Now, managing a patient which is preoperatively diagnosed is a planned procedure where the thorough preoperative workup, including an ultrasound biomicroscopy, to evaluate the extent of the subluxation can be performed. In opposed to this, an intraoperative subluxation is an unplanned procedure. Almost always the surgeon cannot anticipate what is the entire extent of the subluxation. I'd like to now share with you what I consider the important surgical principles in the fixation of a grossly subluxated capsular bag. The first thing you need to know what is the exact extent of the subluxation. Having decided that, you need to then find out what is the point of fixation, which should be at the midpoint of the subluxation. I'm interested in teaching the technique of creation of the Hoffman process. A guarded jackknife is taken to make a clear corneal incision at the limb base. From here, you take a reverse inner tunnel, which is performed with the help of a crescent. And what you end up creating is a 2 millimeter by 2 millimeter scleral pocket. In these grossly subluxated cataracts, because of the lack of adequate stress, performing a capsulolysis may be difficult. Sometimes you may require capsulolysis forceps in order to propagate these fractures. What we do sometimes find is an excessive rocking movement of the nucleus as well as folds into the anterior capsule. One can use capsular bag hooks to stabilize the capsular bag before the physical emulsification. The number of hooks required depends upon how many and how extensive is the sonnular dialysis. So an important learning here has been the following. When you have a patient with an intraoperative sonnular dialysis, just using iris alone without the use of a CTR may not be adequate because since you cannot tell how extensive is the sonnular dialysis, sometimes even with the most comfortable sacral emulsification with slow motion, the entire bag may be sucked out. So what I really find is useful is that along with the introduction of iris loop, please put in a CPR always because this causes a nice set and a stable capsular bag without any problem. Now, hydrodissection in these grossly subluxated cataracts, I prefer to do after the introduction of the CPR because it gives you a stable bag even for the hydro procedure. Nuclear emulsification is done under slow motion figure with markedly reduced settings. Now, irrigation aspiration we know can be challenging because you have some amount of cortex between the equator and the CTR. So sometimes when you hold the cortex with the irrigation with the aspiration cannula and drag it towards the open end of the ring before pulling it out. Insertion of the IOL also should be done extremely slowly, carefully, and cautiously. I prefer to put in the IOL in the bag before the CTF for two reasons. One, because it offers protection to the posterior capsule to avoid any accidental damage to the posterior capsule while the passage of the needle. It also allows for assessing how much the scleral suture needs to be tightened by showing you how well stabilized the capsule should be. Iris hooks can be used to retract the iris in the area of fixation. Let's move to the scleral fixation with the CTF. Manual dexterity is paramount because you need to work at any clock hour depending on where the subluxation really is. This is a capsular segment made of 180 degrees of a loop. It has a central loop with an anterior elevation and a tiny eyelet. One of the needles connected to genopole filter is passed through the eyelet. One needle is passed from the main incision and is exteriorized to come to the eye at a point opposite the point of the proposed fixation. The capsular junction segment is now introduced into the capsular bag and placed well at the point of proposed fixation. The second needle is also similarly exteriorized. Now both needles come to lie opposite the point of fixation. The capsular hooks are now released to relax the iris a bit to allow for ease of passage of needles from the ciliary body into the supracapsular space. A 26 gauge will introduce 1.8 millimeters behind the limbus via the Hoffman pocket into the supracapsular space. Now, turn by turn, one needle followed by the other are railroaded and exteriorized and come to lie outside. Once both the needles are exteriorized, the needles are cut and the suture ends are kept along. The cut ends of the sutures are removed out of the Hoffman pocket and they are tightened into a 3-1-1 knot. The extent of tightening is just adequate to give you a perfectly perfectly centered IOL. And here are the last few learning points. It's better to use a curve rather than straight needles, because these straight needles, while getting sterilized, can push backwards and actually endanger the posterior capsule, resulting in a posterior capsular retina. The other learning is an ab external technique, where if you were to take the straight long needle directly via the Hoffman pocket to the other side, it is technically rather challenging. And finally, I think we shouldn't be dissatisfied when we successfully end up fixating one part of the capsular bag. While sometimes tightening the suture, you might actually find that the opposite side of the bag is also subluxated. Thus, be prepared to perform a fixation at more than one place, and always keep a standby capsule tension segment or a stony ring and another set of features. With this, I come to the end of my presentation. Thank you very much.
Thank you, Dr. Sphira, for a wonderful presentation. You know, bag instability is really a big challenge. So I have two issues. Where would you prefer a segment, and where you would prefer a CTR or a Sioni ring?
So, I mean, so any patient that I see mild subluxation, something like 2 or 3 clock hours, sometimes even 4 clock hours, I would get away with a capsule tension ring placed with a hand-on-hand maneuver. Anything more than that, I would use a capsule tension segment. I'm not very comfortable with the Sioni ring. I would rather use 2 capsule tension segments if I need to, but it's almost always, if I have a 5 clock hour subluxation, a capsule tension segment sutured at the midpoint of the subluxation works. The other indication for a capsule tension segment is if you put in a CTR, but you can actually see the edge of the CTR, it means that even though the CTR is in, you've got a bit of a decentration of the bag, and such bags are not stable just being left alone with a CTR. Even in these cases, along with the CTR, I would scleral fixate a capsule tension segment. This is largely my gross demarcation of when I would use a CTR or a capsule tension segment.
Another issue, what would you prefer, segment or scleral fixation haptic itself?
Okay, my experience with scleral fixation of haptics is not that exciting. I don't have that much of an experience. Plus, I would prefer to keep the IOL where it should be in the bag. Exactly. And I'll be happier to fixate the bag in its natural position and then place a lens which is designed for in the bag fixation to remain in the bag. That's just a personal preference. That's what I would do. And if it is beyond the scope of me managing it, I would wholeheartedly hand it over to my retinal colleagues who in our hospital do a scleral fixation of an SFIOL. That's what they do. So I keep a VR standby always, because sometimes you think you can manage, but when you go and assess the situation, it's way out of hand. So I plan the surgery so that they're around, and if I need them to take over, I'm not postponing the surgery for another day. It gets done the same time. And a consent is taken for all of the above, because these cases are sometimes slightly unpredictable, sir.
So I believe the extended consent is very important in these patients.
Yes, absolutely.
We have to go in for the high risk consent in these patients.
Gee, sir.
Because they can land up with a long-term complications.
Yes.
So the patient has to go in for the.
Absolutely.
And for the Hoffman's pocket, I just wanted to know.
Yes,
you are going through the pocket through the sclera full thickness, and then coming out with the needle and then cutting the suture.
Yeah. So
I didn't get that point.
So when you've created your Hoffman pocket, it's very important. It's very important to know what is the posterior extent of it. Sometimes it's worthwhile marking it with a blue pen as well. Then you have to stay anterior to that point, correct? Because the suture has to come out. If you have by accidentally gone beyond the Hoffman pocket, the entire plot is lost. So it's certain that you know what is the correct dimension of your Hoffman pocket. Come slightly anterior to it, be somewhere like 1.5 to 1.8 millimeters behind the limbus. Take a 26 gauge needle, go through the Hoffman pocket, come out through the supracapsular space into the AC behind the iris, and then one by one next to each other, bring both the needles out out into the air.
Out.
Cut the needles, and then jahan pe aapne pocket banaya hai at the limbus, just drag the sutures out. They come out
No,
at the limbus, and then you tighten it, that knot gets buried. I'd like to add one more. Ji,
yeah.
sir.
So you will enter twice, no, with the 26 gauge needle.
Yes, twice next to each other, because that's how it'll come
Yeah.
out. But to be
Yeah.
honest, I also find today that if you make a scleral, a shared groove, 1.8 millimeters behind the limbus, that works just as well, sir. Because creating a Hoffman pocket is not very easy. You see, it bleeds so much. Sometimes accessing the posterior extent is. So nowadays, I tend to just make a shared groove 1.8 millimeters, because the aim of all of this is to just bury the suture, right?
Exactly. Thank
So
you,
a
Dr.
shared
Severa.
groove, but it works just as well.
We are running short of time. Can I request Dr.
All right,
Severa?
thank
you,
you.
Dr. Severa.
Thank
Thank
you
you so
very
much. There's a message
Thank
that we
you.
are running
Thank
short
you.
of time.
Thank you.
The next speaker, Dr. Srijita Mitra,
Yeah.
she's going to speak on
Thank you.
scleral fixation in post-VR surgery, FAKIA,
So,
post-vitrectomy. Yeah.
am I audible?
Yeah.
Good evening to all my seniors. These are really excellent presentations which we are seeing in this session. Today, I'd like to present my talk on SFIOL in vitrectomized eyes.
Ma'am, we can't see your screen. Yeah, now we
It's
can.
visible now.
Yeah. Yeah.
Okay, so a definition of SFIOL. It involves the implantation of IOL by securing it to the sclera using surgically created tunnels or sutures. They are broadly classified into sutured or sutureless. While there is no consensus on the target spherical equivalent while implanting SFIOL, a study by Abbey et al. Have seen that they have had relative success while using in-bag implantation target of approximately -1 diopters. Now, the pros and cons of operating in a vitrectomized eyes. IOL manipulation can be done safely. There are minimal chances of disturbing the vitreous base and causing iatrogenic retinal breaks. However, the tunnel construction can be difficult in a soft globe if you are implanting in the primary surgery. There might be risk of transient ocular hypertension in eyes with anterior vitrectomy, risk of choroidal or vitreous hemorrhage IOL tilt due to hypotony in the eyes with PPV. I'd like to skip the evolution of surgical techniques. Melbourne et al. Were the first to conceptualize the concept of sutured SFIOL in the 1980s. And Lewis had introduced the concept of docking a straight needle into a 28 gauge needle in the 1990s. And there were internal approaches which were also experimented in the 1990s. But theoretically, they increase the risk of devastating complications like RD and suprachoroidal hemorrhages. This is the Lewis technique, which has been commonly used. Now, the 4-point fixation without the scleral flap railroad technique is also similar to Lewis technique, except for the fact that the triangular scleral flaps are not made in this technique, but the sclera is pierced in 4 points by 2 separate 10-0 polypropylene sutures. In 2006, Hoffman had introduced the corneoscleral pockets that do not require conjunctival peritomy but allow for adequate coverage. These are the Hoffman pockets. Coming to sutureless techniques, Chariot, Gabor, and co-workers were the first to be credited with the description of sutureless interscleral handshake technique that utilized the 24-gauge cannulas to create diametrically opposite ab-external sclerotomies at a distance of 1.5 to 2 millimeters from the limbus. Abbey and co-workers had subsequently described a similar technique for sutureless intrascleral technique that did not require a conjunctival peritomy. With this approach, they had just used 25-gauge strockers to create 3 mm transconjunctival scleral tunnels that are 180 degrees apart from each other. Ota et al. Used scleral flap to embed the haptic in the Y fixation technique. Another adaptation of the sutureless intrascleral technique was recently described by Yamane and co-workers, where they inserted a 3-piece IOL into the anterior chamber. They used a 27 gauge needle to create a scleral tunnel at a distance of 1.7 mm from the limbus. In place of sutures, fibrin glue was used to secure the haptics by Agarwal et al. In 2008. This is the commonly trending Yamane technique. I have a small video showing Yamane technique, where we have used a 3-piece IOL. This was a case of blunt trauma case where the patient had presented with iris prolapse and vitreous hemorrhage and posteriorly dislocated IOL. I had done the vitrectomy and retrieved the IOL in the first setting, and after 3 weeks, I had posted the patient for SFIOL. In this, we can see that I'm using a bent 26 gauge needle, and I'm docking the leading haptic using a 25 gauge microforceps into the needle, and then I'll be externalizing it. We had initially marked 2 diametrically opposite points for entry, created a approximately 2 mm intrascleral tunnel, and then entered or dived into the eye. So now we cauterize the end of the haptic. Now I'm docking the trailing haptic into the needle. And externalizing, and similarly I'm going to cauterize the end of the haptic on the other end. So the challenges commonly faced in this technique, the haptic insertion might be challenging. The scleral tunnel and sclerotomy are too close. Docking the trailing haptic is always very challenging because there's a risk of haptic slippage, kinking, and breakage while docking the trailing haptic, and poorly centered IOL. Pearls for this technique, we might not externalize the leading haptic completely because that makes it very difficult to dock the trailing haptic. Second, sclerotomy should be diametrically opposite to the first sclerotomy. Anterior vitreous should be completely removed. AC maintainer or infusion port should always be present to prevent hypotony. We may do a PI to prevent a pupillary block. An adequate cauterization of the haptic should be done to prevent slippage of the haptics. So based on this technique, Bhaskar et al. Had described the XNet technique where the docking needle had a silicone stopper. Khatri et al. Had used a 27 gauge needle intrasclerally guided by a hollow viscocannula. Takayama et al. Had described the lock and lead catheter guided 30 gauge docking needle. A latest technique by Kanabrava is a 4-flange technique where he has used 50 proline sutures to thread the eyelets of the IOL and flange the 2 points, and then he, in a similar fashion, he has taken out this. He had taken out the suture from the site of the sclerotomy and flanged them in the 3rd and 4th point. I have a small video showing this technique as well. Here I have threaded the eyelets of the haptic with the 50 proline suture and flanged the ends of the suture. This was a case of a Marfan syndrome patient. In the primary surgery, I had done vitrectomy and removed the nucleus. And similarly, after 3 weeks, I had posted for SFIOL. The pupil was very small, so I had to use iris hooks. Here I'm externalizing the suture attached to the leading haptic. The main problem which I faced in this technique was I had made the knob on the eyelet suture quite big, so it was getting entangled in the iris. Shortcomings of SFIOL and sutured SFIOL, there is a risk of late onset endophthalmitis due to erosion of conjunctival tissue, not exposure, suture breakage, and late dislocation of IOL. Initially, 10-0 polypropylene sutures were being used for the sutured techniques, which are more prone to erosion, and they have now been replaced by 9-0 Prolene sutures and 7-0 Gore-Tex. There are
Requesting
also.
doctor to wind up because we don't have any time.
Okay, I'll just skip all this.
5:27. We have to wind up first.
Yeah. Okay. Should I? Okay, I'll just skip this. Differences between sutured and sutureless SFIOL. Ganical et al. Have seen that post-operatively the visual acuity is similar. In sutured IOL, the risk of post-op complication of glaucoma inflammation is more compared to the fibrin glue group. And another study in which Hoffman pockets were compared to Sharot's SIS technique, in which dislocation with sutureless techniques is more. SFIOL in anterior vitrectomy versus pars plana vitrectomy in a recent prospective study, complications were evaluated. Visual acuity improvement was similar in both the groups. Lens dislocation was seen more in the AV group. Myopic shift and IOL capture was seen more in the pars plana group. And intraocular pressure elevations were seen more in the AV group. Primary versus secondary implantation, there is no outcome in the visual
Sorry
visual
to
acuity.
interrupt you, ma'am. I would request you to please sum up in next 30 seconds as we are running short of time.
Yeah. I'm done. And SFIOL in silicone oil filled globe should be done after silicone oil removal. Astigmatism is also very much significant. So the take-home message is the procedure of choice in eyes lacking in both iris and capsular support is SFIOL. However, sutureless techniques are gaining more popularity because there is more maintenance of ocular anatomy and tissue integrity, and availability of specialized instruments is very much necessary in implantation of SFIOL. However, there is a shift towards retropupillary IFIOL because they have an easier learning curve and less time consuming. Thank you. I'd like to thank Dr. Shakeen sir for giving me the opportunity to speak on this session. Thank you.
Wonderful presentation, Dr. Srijita. Thank you so much for the presentation. Since we are running short of time, I will quickly try to wind up this session. So first of all, thank you to Dr. Shakeen Singh for wonderfully moderating this session, and thank you to all the speakers for their wonderful presentations. We have come to the last leg of this session, and we have inauguration starting at 5:30. So I would request everybody to please move towards the inauguration hall.
Diksha, we are left with one presentation still. Can we go ahead with this or not?
Sir, we have to wind up, sir.
I'm so sorry
Right
to
now.
say, but we have to wind up. Yeah.
No problem. Thank you. So I must thank all my co-instructors, Dr. Swera, Dr. Dinesh, Dr. Rajesh, Dr. Srijita. Thank you so much for being with us. Thank you.
Thank you, sir. Thanks.
Thank you so much, sir.
The admin group also. Thank you.